Atul Gawande. Some people are surgeons. Some people are professors. Some are international public health activists. Some are researchers. Some are staff writers at The New Yorker. And some even writers of award-winning international bestsellers. But only you are all of these. I think your cape is showing. Your twin passions are to improve the care provided to patients, your own and others, and to show how healthcare, despite its technological advances and its business model, remains full of human fallibility, mystery, and uncertainty. Your research focuses on transforming safety and performance in surgery, in childbirth, and in the care of those who are dying, and particularly on the seemingly small steps that, because they are easily replicable, can have pervasive effects. You are lead advisor to the World Health Organization's Safe Surgery Saves Lives program, and the founder and chairman of Lifebox, an international nonprofit working to reduce surgical deaths worldwide. No wonder that Time magazine has named you one of the world's top 100 influential thinkers. Long may you continue to shine as such a public example of a healer who combines the best of both mind and heart. I hereby declare you recipient of the honorary degree, Doctor of Science, entitled to all the rights, honors, and privileges appertaining thereto. It is our custom to ask one of our honored guests to speak on behalf of the entire group of recipients of honorary degrees. This year, we will have the pleasure of hearing Dr. Gawande.
Thank you for this honor, but most of all, congratulations to the class of 2012, to the families, and to the faculty who all brought you here. I want to tell you a story about a patient of some of my colleagues at my hospital this winter, because her story has stuck with me. Mrs. C was 87 years old, a Holocaust survivor from Germany, and she'd come to the emergency room because she'd lost the vision in her left eye suddenly. It tells you something about her that she was at work when this happened, in the finance department at Sears. She'd worked her entire life. When her family left Nazi Germany, they narrowly avoided the concentration camps, but ended up among 20,000 Jewish refugees relocated to the Shanghai ghetto in Japanese-occupied China. She was a teenage girl and spent 8 years there helping her family just to live and survive until liberation in September 1945. She was denied a formal education, so she worked as a seamstress upon admission to the United States. She rose to head seamstress at Bloomingdale's in Chestnut Hill, outside Boston. She married at 23, had 2 sons, and was widowed at 44. And all the way, she remained in remarkably good health. At 87, she still lived independently in a second-floor apartment in Norwood, Mass. She drove a Honda Civic. She did all her own shopping and cooking, and she still worked 3.5 days a week at Sears doing office work, and her other weekdays volunteering at New England Sinai Rehabilitation Hospital. She was sitting at her desk at Sears when the vision in her left eye went completely black. Came back after 3 minutes, and so she dismissed the episode. But the next day, the same thing happened again, only this time the vision didn't come back. Her doctor sent her to our emergency room, where she was suspected to have had a stroke caused by a severe atherosclerotic blockage of the carotid artery in her neck. She needed urgent surgery to open that blockage, and she thought hard before agreeing to it. She didn't even want the tests. She had great fear of the risks and what they could take away from her life. But she had greater fear of what her condition might take away. Being able to be independent, work, and contribute in some way was most important to her, even at 87. And her best chance of preserving this was to act. The operation went well. There were no problems at all. She ended up the next day weak, but she got out of bed. She ate. She felt fine. The day after that, she seemed ready to leave the hospital, but she complained of constipation and that it was making her nauseated and uncomfortable. The team tried various medications, but they did nothing, and her belly only became more painful. A young resident was the one who, looking at her, felt something wasn't right. In fact, this wasn't constipation at all, but a disaster from a strange complication. Her stomach had twisted on itself, pulled up into her chest, and become trapped, a rare condition called gastric volvulus. Worse, an ulcer seemed to have formed in the lining and ruptured into her chest. This is catastrophic for anyone, let alone someone at 87. The textbooks describe an 80% fatality rate. Yet she survived. She, in fact, left the hospital with her son within the week. And the more I reflect on the story of how that was made possible, the more I think the story is relevant to all of us, no matter what our walk of life. When I was nearing the end of medical school, I decided to go into surgery. I had become enthralled by surgeons, especially by their competence. The source of their success, I believed, was their physical skill, their hand-eye coordination and fine motor control. But it wasn't, I learned in my residency training. Getting the physical skills is important, and they take some time to practice and master, but they turn out to be no more difficult to learn than the ones Mrs. C mastered as a seamstress. Instead, the critical skills of the best surgeons I saw involved the ability to handle complexity and uncertainty. They had developed judgment, mastery of teamwork, and willingness to accept responsibility for the consequences of their choices. In this respect, I realized surgery turns out to be no different than a life in teaching, or in public service, or in business, or in almost anything else that you might decide to pursue. We all face complexity and uncertainty no matter where our path takes us. That means we all face a risk of failure. So along the way, we're all forced to develop these critical faculties of judgment, teamwork, and acceptance of responsibility. In commencement addresses like this one, people always admonish us, take risks, be willing to fail. But I've always been puzzled by that. Do you want a surgeon whose motto is, I like taking risks? We do, in fact, want people to take risks, to strive for difficult goals, even when the possibility of failure looms. But progress can't happen otherwise. And still, how you do it, how you deal with failure, is what seems to matter. The key, it turned out, to reducing death after surgery was the introduction of ways to reduce the risk of things going wrong. Through specialization, better planning, technology, they've produced a remarkable transformation in the field. Not that long ago, surgery was so inherently dangerous you would only consider it as a last resort. Large numbers of patients developed problems like infections, bleeding, and other deadly problems we euphemistically called complications. Now, surgery's become so safe and routine that most is day surgery. You go home right afterwards. But there continue to be huge differences between hospitals in the outcomes of their care. Some places still have far higher death rates than others. And an interesting line of research has opened up asking why? Why are some places so much better than others? Some researchers at the University of Michigan discovered the answer recently, and it had a twist I didn't expect. I thought that the best places simply did a better job of controlling and minimizing the risks that they took, that they did a better job of preventing things from going wrong. But to my surprise, they didn't. Their complication rates after surgery were almost the same as others. Instead, what they proved to be great at was rescuing people when they had a complication, preventing failures from becoming catastrophe. Scientists have given a new name to the deaths that occur in surgery after something goes wrong, whether it's an infection or some bizarre twist of the stomach. They call it a failure to rescue. More than anything, this is what distinguished the great from the mediocre. They didn't fail less, they rescued more. This in fact may be the real story of human and societal improvement. Risk is necessary. Things can and will go wrong, but some have better capacity to prepare for the possibility, to limit the damage, and to sometimes even retrieve success from failure. When things go wrong, there seem to be three main pitfalls that you need to avoid, three ways to fail to rescue. You could choose a wrong plan, you could choose an inadequate plan, or you could choose no plan at all. Say you're cooking, and you inadvertently set a grease pan on fire. Throwing gasoline on the fire would be a completely wrong plan. Trying to blow the fire out would be an inadequate plan. And ignoring it, fire, what fire, would be no plan at all. In the BP oil disaster in the Gulf of Mexico 2 years ago, all of these elements came into play, leading to the death of 11 men and the spillage of 5 million barrels of oil over 3 months. According to the official investigation, there had been early signs that the drill pipe was having problems and was improperly designed, but the companies involved did nothing. Then on the evening of April 20, 2010, during a routine test of the well, the rig crew detected a serious possibility, in fact, serious abnormalities in the pressures in the pipe. They watched it, they took more measurements, they found more abnormalities that signaled a kick, an undetected pressure buildup. But they convinced themselves, maybe this was something else. And so it was 2 hours before they realized the seriousness of the situation. 2 hours without a plan of action. Then when they did recognize the trouble, it sent the flow through a piece of equipment that couldn't handle that kind of pressure. The kick escalated to a blowout, the mud gas mix exploded, and at that point, emergency crews went into action. But for 12 minutes, no one sounded a general alarm to abandon the rig, leading directly to the loss of 11 lives in a second explosion. There was, as I said, every type of error, but the key one was the delay in accepting that something serious was wrong. And we see this in lots of ways. We see this in national policy, too. All policies court failure, our war in Iraq, or the effort to try to stimulate our troubling economy. But when you refuse to even acknowledge that your plans aren't going as expected, failure can become a humanitarian disaster. The sooner you're able to see clearly that your best hopes and intentions have gone awry, the better. You have more room to pivot and adjust. You have more of a chance to rescue. Recognizing that your expectations are proving wrong, accepting that you need a new plan, is commonly the hardest thing to do. We have a problem called confidence. To take a risk, you must have confidence in yourself. In surgery, you learn this very early on. You are imperfect, your knowledge is never complete, your skills are never infallible, yet you have to act. You cannot let yourself become paralyzed by fear. Yet you cannot blind yourself to failure either. You have to prepare for it. For strangely enough, only then is success possible. When Mrs. C's abdominal pain turned to catastrophe, for instance, my colleagues were prepared. Now, they weren't prepared for anything so odd as the idea that her stomach would have wound on itself like a balloon twisted too tight. In fact, when the surgical resident told Mrs. C's lead surgeon that he was concerned about the way her abdomen felt on his exam. The surgeon thought he was being alarmist. She'd been doing great the day before. What could go wrong in someone's belly after neck surgery anyway? He'd never seen a serious belly problem in such circumstances. But the surgeon was humble enough to understand that he could. You never know which way trouble can strike. So he listened. He allowed the resident to order the scan he wanted to get. The team made sure it was expedited. When it showed the queer twist, no one dismissed it. They got help from another surgeon immediately. They had her on an operating table within 2 hours. Nothing went exactly perfectly. There was still a good deal of fumbling around as they tried to sort out what was really going on and what should be done. For a time, they hoped for a small, short procedure, just using a scope and avoiding a big operation. And that would have been an inadequate plan. But they avoided the worst mistake, which was to have no plan at all. And so they acted early enough to buy themselves time for trial and error, to figure out the steps required to get her through. They gave her and themselves the chance to rescue success from failure. I spoke to Mrs. C a couple days ago. She's living with her son now. She turned 88 this past April. With her vision gone in her left eye, she can't work anymore or drive, and she misses both greatly. I'm not the same person I used to be, she told me. She doesn't like being dependent on others, even for just a ride, but she has otherwise returned to leading a life of her own. She enjoys her family, especially her grandchildren, and she's even looking for ways to volunteer again. Life is not perfect, but it's good, she said. As you embark on your path, you're going to take chances on a relationship, on a job, a new line of study. You'll have great hopes, but things won't always go right. When I graduated from college, I went abroad to study philosophy. I hoped to become a philosopher, but I proved to be profoundly mediocre in the field. I tried starting a rock band. You don't want to know how awful the songs I wrote were. I wrote one song, for example, comparing my love for a girl to the decline of Marxism. After this, I worked in government on healthcare legislation that not only went nowhere, it set back the prospect of health reform for almost 2 decades. But the only failure is the failure to rescue something. I took away ideas and experiences and relationships with people that profoundly changed what I was able to do when I finally found the place that was for me, which was in medicine. So you will take risks, and you will have failures, but it's what happens afterwards that is defining. A failure often does not have to be a failure at all. However, you have to be ready for it. Will you admit when things go wrong? Will you take steps to set them right? Because the difference between triumph and defeat, you'll find, isn't about your willingness to take the risk in the first place. It's about mastery of rescue afterwards. Thank you.